Just a little bit of background on me. I have actually been doing hospice since 2017. Prior to my hospice career, I did pediatric oncology. So I was talking to these lovely people here about kind of what it looked like back when I started pediatric oncology and where we are now. Because if you guys remember better than me, back in the 60s, what the prognosis was for kids with cancer, it's terrible. It's terrible. And now, when you see a patient, a pediatric patient who is diagnosed with cancer, 80% of children in this country diagnosed with cancer are cured. I don't mean go into remission for it to come back 6 months or a year from now. I mean cured. So yeah, that was a really rewarding field. And people are always like, oh, that must be so depressing. No, it was very, very rewarding. So why did I end up doing hospice? I had a family member who was in hospice. And when he went into hospice, I thought, you know what? I learned a lot through this experience. And I think that I have a lot to offer this field. So I did a second fellowship. So that's after you finish medical school, you do a residency, and then you specialize. So I had done medical school, residency, I had already subspecialized in pediatric oncology, and then I did another subspecialty in hospice and palliative medicine. And then I've been doing hospice since I completed that in 2017. So it is also a very rewarding career. I'm able to walk with patients and families during some times that are the most stressful in one's life. And I have things to offer some of these families that I can say, you know what? I've been in your shoes. I've been with a loved one who was at their last days, and some of the things that I see families suffering with, I personally suffered with. And so I do feel that I have a lot to offer this specialty, and I've really enjoyed walking. It's been an honor to walk with these families and patients during these critical times in life. So thank you again for having me. I do want to talk a little bit about hospice, what it can be, what it is meant to be, and how we can help patients and families, because it is a gift. So if you I was talking about my grandfather last night to my sister, and we were talking about family history because, you know, I'm the family historian now. And so, you know, she said, well, what did Grandpa die of? And I said, he had a heart attack. But it was 1969. So what happened in 1969 when you had a heart attack? You die, right? And that was 1969. That was not 1990, right? So now there is so much more to be done for patients. Now we have greatly not only improved your lifespan, but your quality of life. Because if you had a heart attack back then and survived it, you likely had a lot of physical limitations, things you couldn't do anymore because they weren't able to fix the underlying problem. So you really had significant limitations. So not only have we improved lifespan, we've also improved quality of life. So back historically, back in the 1990s, 4% of the America's population was greater than 65. Only 4%. I'm suddenly feeling quite old, right? In 1900, life expectancy was 49. So there you go. I mean, Lucy, 49. And most people died at home, surrounded by their family. And when they passed, you know, the end of life experience was very different for those patients and families. So what does that look like today? Today, nearly 15% of the US population is over 65 years old. It's still a low number, especially when you think 65 isn't that old, sorry. But up from 4%, so that is a huge, huge difference, right? And our life expectancy is now 78.7 years, okay? That's huge. And like I said, it's not just a question of life expectancy, it's also the quality of that life. And about 37% of Americans die in acute care hospitals. And 19% die in nursing homes, so very few have the opportunity to die at home surrounded by their loved ones. That's a huge impact. Big differences. In many ways, we've come a long way, baby, Virginia Slims. But in many other ways, maybe not. So back in 1967, if you guys heard of Dame Cicely Saunders, she actually opened the first hospice house, St. Christopher's Hospice House in London. That was 1967. And in 1969, you remember that old book that talks about on death and dying, the 5 stages of death? You know, people started talking about it. People started talking. And in 1974, in the United States, we had the New Haven Hospice of Connecticut was first established. In 1976, so 2 years later, Hospice Care Inc. was established, and now that is now Vitas. Okay, so Vitas has been taking care of patients in the United States at end of life since 1974. 1976. In 78, they established the National Hospice and Palliative Care Organization. That, you know, how there's certain organizations who really kind of direct us on how to care for patients, how to take care of people. And they came up with this NHPCO, and they said, we need to lead and mobilize social change so that we can improve care at the end of life. That is their goal. So when we think about what is hospice, because a lot of people, thank you for coming, because I know that you guys aren't afraid of the H word, right? A lot of people think of hospice as the H word. A lot of people think of it as something scary and to be avoided. So it is an insurance benefit. You know how when you think about benefits, you don't want to use your benefits, right? But it's there when you need it. I don't want to ever have to use it, but when I need it, I'm going to want it. So it is an insurance benefit. You paid for this, you know, one way or the other for years you've been putting into the system, whether that's Medicare or whether that's your service for our country. You have put into this, and there does come a time where you can benefit. If you're able to benefit from that, it's available. So it provides home-based care. So whatever you call home, hospice comes to you. You don't have to go to hospice. Who likes going to the hospital? Okay, I was going to say as a patient. As a patient, right? Because when you go as a patient, a lot of things happen. Some of them are good, and some of them is kind of like the train that gets derailed. And you've got to wonder, where are you going? Wait a minute, did you just throw me off the train? Because I don't know where I'm at, right? You do tend to lose control of some of the things that are being done. And you do have to question, there does come a time when you start to wonder, are these things being done for me? Or are they being done to me, right? Because you do need to be able to have a say in what is important to you and what you want to have done, right? And it hurts my heart, but when I see an elderly person who is not talked to, they walk into the room and say, who is your MPOA? Because you're elderly. That's not fair. That is not right. We do not jump over the head of someone because of age discrimination, because we're worried that they're not able to talk to us on what's important to them. If the patient's able to have that conversation, they should have the right to do that. We don't leave you out. And we want to provide that home-based care. Hospice, people think about it as withdrawing care. They think of it as stopping aggressive treatment. Hospice is aggressive symptom management that's going to allow you to live as well as you can for however long you have, right? And it may be hours, it may be days, it may be months. And I have had a couple of patients who have been on hospice for a couple of years, right? One who's here. And the focus of hospice is on quality of life. How can we make the quality of your life as best as it can be? So, instead, because when you go to the acute care hospital and you're in the ICU and you're having these things done, what is the focus of their care? Their focus of their care is trying to make sure that you have a longer life, right? There does come a time where you say, is it more important to add days to your life or life to your days? When is that? I'm not going to tell you. It's you that it's happening to, right? So I want to know what that time is for you, not vice versa. Does that make sense? Answer? Okay. So what do we have as part of the hospice benefit? Because sometimes people really want our services, but they don't know it's hospice, right? And if I talk about what we can do for someone and their family, because it's not just the patient, it's their support system as well, right? So when they hear what we can do for them, they're like, oh yeah, that sounds like a really good idea. And then I'll say, so that is hospice. Oh my, you know what? That actually sounded like what I need though. So we do have an interdisciplinary team. We go out and see patients in their home, where their home is by themselves, with their family, assisted living, memory care, nursing home, whatever their home is. We go to you. So you have a nurse who comes out and visits you, right? If you need once a week visits, you get once a week visits. If you need a nurse to come out every day because you're having something going on, then you have a nurse who's going out there every day to address that. We have aides. Now, aides are very important, and let me tell you, if you love anyone, you love your aide, because our aides will go out and help bathe, keep you clean, and that not only helps you, that helps your loved one who's been doing that for you, right? Gives them a break, because it does get more physically demanding as someone's condition changes. We also have full-time physicians. With Vitas, we have full-time physicians, but any hospice will have physicians who kind of are watching the entire patient, and we not only look at the physical problems, but also any psychosocial issues, any spiritual issues, because we look at the patient from a holistic approach. Okay. I mentioned the nurse. We have social workers and chaplains as part of our team. They'll come out and visit you in your home. There are many times when it's like, I need help because I've gotten this bill and I'm trying to figure out what's going on here. Maybe the social worker can help me work through this and tell me how to address this. And sometimes it's like, you know what, I'm really struggling with mom's decline. Can you come out and talk to me? Let's do that, okay? And for chaplains, not everyone is religious. There many people are, but not everyone is. And we will minister to patients and families of all or no faith groups, okay? So yes, we do have priests on our service for the special sacraments, but we also have chaplains who are lay people who address spiritual concerns. Sometimes that spiritual concern is, what is the meaning of life? I've been here for 75 years, and now I'm struggling with my decline. Can I talk to someone about what has been the meaning of this? They may or may not be a religious person, but chaplains have special training in hearing that spiritual distress, spiritual need to have those conversations. We also have volunteers. If you guys have seen the memory bears that we make, we have a wonderful group of seamstresses who are volunteers with us, who make memory bears for families using the clothing of the person who has passed away. We also have volunteers in many different areas as well. So that's part of the insurance benefit. Hey, if I tell you we can get this out to you in the home, and you don't have to go into the doctor's office to see a nurse, to see a physician, to have these things ministered to. That's a real pull, that's a real appeal there. We also provide medical equipment. So if you guys are having to rent hospital bed, bedside commode, those things, that is part of the insurance benefit, and we provide those medical equipments that are needed for the patient to stay as mobile as they can and safe and comfortable with those equipment. So we do cover that. And any medications that are related to your hospice diagnosis are covered. Because I think that medications are just a little bit expensive. Just a little bit. Also, we have bereavement services. Because when we recognize at the end of life, patients aren't worried about themselves as much about their families. So I work a lot in our inpatient hospice unit when patients are truly at the end of life. And I will tell the families, please recognize that part of taking care of your dad is taking care of you because he's worried about you. He has peace knowing that we are here to support you and answer your questions. That doesn't just apply to our inpatient unit. We have most of our patients actually have the gift of being able to pass away in their home surrounded by their family. We help walk families through this end-of-life process. We provide them the training and the education so that they are ready to be able to provide the help the person needs. And that is a gift. I've met many patients who the most important thing to them is at the end of life they want to pass at home. So they can rest assured that we will be there to support their families as well. So after someone has passed away, we are there for, it says a year because that's what's required by regulations, but we actually cover 13 months of bereavement because we know how important anniversaries are. So we do provide, with Vitas, we do provide 13 months of coverage for bereavement for families. What do we have? We have grief education resources. We'll send letters, cards. We'll get on the phone, call the family up. How are you doing? We know something important is happening. This might be your wife's birthday. So how are you, right? To provide those phone calls. We also have some bereavement support groups as well. We have annual memorial activities, and as I mentioned earlier, the memory bears, because it's such a comfort to hold on to something that reminds you, it's like this was her favorite shirt, and it's part of this bear. So when you ask someone, what's the most important thing to you as you are facing a terminal illness? It may be very quickly, or it's a terminal illness that you still have some time, right? Not every terminal illness is a rapidly progressive one. So what's important to patients, what they say, I'm not making this up, we asked you guys, what's important to the end of life? Symptom control. So that's why we talk about aggressive symptom management. We want to make sure your symptoms are controlled. Avoidance of inappropriate prolongation of the dying process. Because there are things that we can do that will prolong your life, And anyone who's been through some stress, that see that sometimes what we're doing is not prolonging life. Sometimes what we're doing is prolonging the dying process. And that could be prolonging pain or suffering that we're not going to be able to reverse the underlying cause, for example. Right? I did not go to medical school to get my GOD diploma, and anyone who did, I'm pretty impressed. A sense of control. I talked about the runaway train when you're in the hospital. It's like, wait a minute, you're taking me where? To do what? When you are on hospice, and patients also say what's important at the end of life, to be able to have a sense of control, to relieve the family burden, and strengthening relationships with loved ones. Because sometimes there's strained relationships, and that might be a little piece of unfinished business you want to attend to. So that's also things that our social worker and our chaplain, our psychosocial supports and groups, systems can help with. So when I think about and talk about symptoms that patients face at the end of life, they're not just physical, but physical symptoms include pain, shortness of breath, congestion, difficulty swallowing, weight loss, agitation, and I will tell you the most common complaint I hear from patients at end of life is extreme fatigue. They are just so tired they can't keep their eyes open, and they're like, I don't know why, I am just so tired. That's part of the dying process. How many people say I want to die in my sleep? The body was created pretty smartly. We also know that there are psychosocial and spiritual symptoms at the end of life. And when you are in the acute care hospital, when the focus is prolongation of life, that doesn't always get attended to. I'm not going to say never, because I have met some amazing nurses and some amazing social workers at hospitals who will actually go in and talk to patients or families about some of these symptoms, but it is not the norm, right? So you can have depression, anxiety, difficulty with coping, difficulty being able to communicate, and life role transitions. Suddenly, I was the breadwinner, I was the caregiver, and now I have become the person needing care. That transition is really emotionally difficult. So, to kind of wrap your head around that, and also the caregiver distress. You could have symptoms of despair, hopelessness. Let's talk about it. Inability to have power over what's happening, lack of meaning of life, and loneliness. So, to be able to address all those needs is so critical and imperative. So this is a great insurance benefit. When can I have it? Right? So it is very difficult to prognosticate. What I mean by that is very hard to know exactly when we have 6 months. It's not stamped on our forehead, right? But when you have a condition, that if the medical condition continues on its expected course, the way it's been going, would the life expectancy be 6 months or less? Once we can say, and that's a clinical determination, once we say, yeah, 6 months or less, then you're eligible for hospice, okay? So you do have to have an overall health conditions that together looks like your prognosis is limited to 6 months or less. Having said that, I mentioned that sometimes people are on service for a very long time. Let's say you have a very advanced condition, and today I can look at a patient and say, I would not be surprised if they passed within the next 6 months. Medicare asks us to evaluate that every couple months to say, what about now? What about now? So our job is to take a look at the patient's condition and say, has something changed? Or do we still feel that the patient's prognosis is 6 months or less? If it is still 6 months or less, then they can stay on hospice. Having said that, some patients graduate, right? So let's say, for example, I took care of a lady last year who had had a stroke. And she was very debilitated from the stroke. They chose not to pursue rehab. They just wanted to go home and stay comfortable. Peg tube, everything. And then she started getting better, communicating, because she wasn't talking anymore, being able to start to swallow some food. And we did get to the point where we said, you know what? You've graduated, because I can no longer say your prognosis is 6 months or less. What do they call that in our PDE group? You failed hospice is the other one I've heard. You failed hospice. They love saying that to the kids. So any pediatric patients that we have, they love it when they fail. Okay. So we also say, are the goals of the patient and the family, is it to focus on comfort care? Do we want to keep going back to the hospital? Do we want to be cared for at our home? What is it that is important? And like I said earlier, it's not my job to tell you, it's your job to tell me. When do you want to start focusing on comfort and stop being aggressive, going back to the hospital? Because I've admitted patients to hospice who in the past 6 months have spent 3 weeks at home. They're done, right? They don't want to do that anymore. But there are other patients who will be like, no, I want to keep doing this. And that's their choice. My job is to elicit what's important to you, not to tell you what's important to you. This is interesting. Percentage of hospice patients by diagnosis is probably too small for you guys to see. Guess what is on the far left? If you look at all patients who are on hospice, what do you think the most common diagnosis is? Cancer, right? But is the number 2 leading cause of death in the United States for adults? What's the number 1 leading cause of death in the United States? Heart disease. We're opposite. So a lot more patients who have cancer have the opportunity to benefit from hospice care than patients with heart disease. Heart disease is number 1. I'll tell you a little bit about heart disease. So almost 30% of patients who get to benefit from hospice, about 30% have a diagnosis of cancer. Only 17.5% have heart disease. But if you look at the causes of death in the United States, heart disease is about 22-25% of people who pass away die from heart disease. And it's only about 17 or 18% of patients who die in the United States die from cancer. Isn't that interesting? That's sad. I think that is sad. So, the number 1 leading cause of death in this country is heart disease. 1 in 10 people who have heart disease, who die from heart disease, only 1 in 10 access hospice. That means 90% of people who die from heart disease do not get the benefit of hospice care and what they can provide. That's huge. So you guys might be a little familiar with American Heart Association. Just a little bit, We look at their recommendations very strongly because the American Heart Association has gotten us from where we were back in the 60s to where we are now, right? Improving longevity and quality of life for many, many patients. So the American Heart Association recently came up with a program that they said, if a hospice company meets these criteria, we will certify them as American Heart Association certified hospice. Guess what? Vitas was the first, and as of right now, the only hospice in the country with the AHA recommendation and certification for hospice. Okay? So, and we're super proud of that. You might be able to tell, right? So, why is that important? One of the things we're super proud of, we've been working on our heart program for over a decade. a long time. And when the American Heart Association came out for guidelines, what a program has to have in order to be certified, we were super proud because we were already doing all those things. So when they came out with the certification, we were able to apply very quickly and say we have it. They reviewed things and gave us that certification. So what do they feel is important? They feel that we need to have enhanced cardiac care. We have all kinds of education for our staff. We make sure that we collaborate and work with referring cardiologists, someone's cardiologist, to be able to give them the best care. And, you know, we just have this incredible commitment to quality where we are constantly working on improving our care. A lot of people ask, I don't know if you guys have heard of this, but when you look at longevity, how long people live, there have been studies done that show that patients who get aggressive symptom management not only have fewer symptoms at the end of life, but they've also been shown to live longer. Did you know that? So the New England Journal of Medicine years ago did a white paper, which is essentially something that everyone looks at because it was so impactful, where they looked at patients with advanced terminal lung cancer, and they gave half of the patients aggressive symptom management, and the other half did not get the benefit of that unless they specifically asked for it, and they both got the same medical care. They found that the patients who were getting the symptom management had their symptoms better managed, which is what they arranged that study to prove. Okay, well, surprise. They weren't going out there to find it, but they found it, that patients lived longer. They lived longer when their symptoms were managed. The study was not powered to find that out, and it did. So that's why it's something we point to. So yes, when you do have your symptoms managed, sometimes you can live longer. And like I told you, you know, if you have a patient who's been in the hospital all but 3 weeks of the last 6 months, you think that you're going to get them home and they're going to pass away quickly. We actually find that we are able to manage those symptoms and we can prolong patients' lives. And I'll talk about why, how. There's some voodoo magic going on there. Because what are we doing that is making this happen? Because there have been a few instances where I can sit back and say, you know, this patient's stable and needs to graduate from hospice, and I've called the cardiologist or their primary care physician, and I've heard they're still alive? Really? I'm not joking. Yes, they are. So why is that? So if you have, let's just say you have advanced heart failure, you don't want to go back to the hospital. So you wait. You start having symptoms. You may be a little short of breath. You may have some swelling. And you're like, I do not want to go back to the hospital. I'm just going to, we are all good. And I'm just going to, you know, men and women of a river in Egypt called denial, right? Don't want to go in the hospital. I don't see that my legs are swelling. So by the time they seek medical care, whether that's calling 911 because they can't breathe, or they're so swollen and their daughter comes to visit and says, I'm taking you to the doctor, by the time they go, they end up admitted, right? So if you have a nurse who's going out to see you once a week, whether you think you need it or not, maybe we tend to catch those things earlier before they become so significant that you end up in the hospital. So we do see patients who have been in the hospital constantly who aren't going to the hospital, and you're like, they're living longer. Because if they hadn't been on hospice, they would have been back in the hospital or they would have passed. So that's a huge benefit, especially if the quality of that life is good. We do come to the point where quality is more important. All of us do, usually. Some people, that's not what they want. Okay, so just a couple of myths. You don't need hospice until you're ready to die. And I can tell you, I have admitted patients to hospice who had passed within 10 minutes. they did not get the benefits of all that hospice can offer. It has been shown that in order to feel that you have benefited from all the services that hospice has to offer, minimum of about 30 days on hospice. So no, it's not just a few days, and the longer you're on service, the more we're able to minister to you, to your family, to improve your quality of life, to give you that quality time, to be able to say, you know what, I'm gonna have a party with my kids. My grandkids are gonna come over and we're gonna make memories, giving you the opportunity to do that. If you wait until you're a few hours or a few days before death, you don't get that opportunity. So no, you don't need to wait until you're just a few days or a few hours from death. People think that it's the last resort when nothing else can be done and that you're giving up. I challenge you. I mentioned that I used to be an oncologist, and I have heard so many families say, we don't want her to give up. There's still hope. And I may know that there are no additional treatment options with the expectation or hope of cure. It's not giving up. It's changing what's important. It's changing your goals. It's changing what you're hoping for. Maybe you get to the point where I wish too that we would be able to give you a treatment that would allow you to live longer. But you do get to the point where you worry that they're going to pass regardless. And to make the quality of that time is as good as it can be is vital. So it is not giving up. It's a time to step back and say, at this time, what's important? When a patient dies on hospice services, we talk to families and say, how comfortable are you with the person's end-of-life experience? And if you take someone who's been on hospice and someone who dies in the acute care hospital, let's say in the ICU, with things being done that don't change the outcome because they have passed away, and we compare that, there's a huge difference. Better symptom relief. How many hospitals are afraid to give comfort medicines for the fear that it'll drop their blood pressure and the patient will die? But they die anyways. And so at the end of life, they were in pain. So better symptom relief at the end of life. Quality of end of life care. Patients receive just the right amount of pain medication to address their pain or shortness of breath. End of life wishes being honored. And this is what I was alluding to earlier. Families of patients who receive greater than 30 days of hospice care reported the highest quality end-of-life outcomes. It's like you have to be on service long enough for us to be able to address these things and give you what's important as your time gets shorter. Because when our time is short, it's even more precious. So this is Cicely Saunders. You matter because you are you. You matter to the last moment of life, and we will do all we can, not only to help you die peacefully, but also to live until you die. Because we do live until we die. I'm going to have some final thoughts for you to think about and consider. What does a good death look like? People are so afraid of asking that, right? It's a hard question to ask. What are your most important goals? Is it that you want to have a barbecue with your grandkids? Is it that you want to reconcile with your son that you haven't seen in 15 years? What are your most important goals? What are your biggest worries? What are you afraid of? What gives you strength as you think about the future? What activities bring joy and meaning to your life? How much would you be willing to go through or sacrifice for the possibility of more time? No guarantees. Possibility of more time. What are you willing to go through? What are your hopes for your health? I can't answer that. Those answers are different for everyone. But when we think about what a good end-of-life experience is, these are some kind of particular questions for us to think about. I think that's all I have. Yes? Yes.
As you know, I've been here before. 4 things sounds like a lot. Number 1, my bear is on my bedside table, constructed from a blue t-shirt. It's the University of Michigan blue. Her name is Miss Blue, and she's there every evening for me. Secondly, I would suggest that everybody remember to put in their computer the words sting, comma, sting, like a wasp sting, comma, so to speak. Refers to Sting, the rock artist. They were constructing a stage show that didn't work out, but one of the themes that they were working on was the producer asked Sting to set a scenario to music. The scenario was a dying Catholic priest with stage 4 cancer sent to a shipyard to relieve the burdens of the workers that were going to be fired. And you can imagine Sting's first thought was, what the heck? But he did it. So Sting, so to speak, contains music and lyrics that I consider the anthem or the theme or the hymn of the hospice movement. It should be so considered, I think. It's, when you listen to it, you understand. Third thing is palliative care, which is a little bit separate, but only a little bit. I chaired committees in the Baptist system that were required by Texas law. But when palliative care doctors appeared on the scene, my life got better. Embedded in their activity is the ability and the desire to talk with the families. How are you doing? How is Uncle Harry doing? Construct that. It doesn't necessarily have to go to hospice, but they palliate the whole situation. There's an editorial in this most recent Annals of Internal Medicine, not an editorial, it's one of the social commentaries that they put in there about a physician who experienced that on behalf of their family and said, please bring in palliative care earlier. And the last thing is, and here I'm repeating something, 2021, my wife went through organ failure, not important why, but total liver and kidney failure. Guided by Dr. Arias, if you know her. And we elected the inpatient hospice over on Medical Drive. It was only a few days, because it was a rapid demise when you're in that circumstance. But my wife, I, and my family we received precisely the care that we needed. And I thank you for your leadership.
The 1 year annual, if the person has already died, how is the insurance taking care of that a year later?
So the question is, how is insurance still taking care of that, still reimbursing a year after the patient has passed away? So part of the reimbursement for hospice includes bereavement services. So there's what's called conditions of participation, that in order to be hospice, in order to be able to receive, reimbursement for hospice care, you need to meet these conditions of participation. One of the conditions is that you must provide 12 months of bereavement services for patients' families. So if a patient's on service on hospice for 2 hours, part of that reimbursement you got for the 2 hours includes 12 months of bereavement services for the family. Okay? If a patient's on service for 2 years, there's no additional billing after the patient dies, of course, but that is part of the benefit.
So I'm probably one of the few people, I don't want to die at home. I can stay at home, but when it starts getting right down to the line, I think I want to be in somebody else's place. Is that part of an option that I would have on hospice? And then I have one more.
Okay, I'll answer that one first, and then she's got another one, so hold on. So there are different levels of service. Hospice does not include what we call custodial care, which is if you're in a nursing home and you need someone to help you, keep you, get you up and out of bed, to change you when you've soiled yourself. Those things, we cannot be the at the bedside help. Okay, so there's a lot of patients who are on hospice, for example, who are in nursing homes because they need someone to care for them and they don't have family to care for them. Okay. At the end of life, some people do start having symptoms. It might be pain because all of a sudden you're not moving around, and the human body was made to move, right? So sometimes it's pain. You can't reposition someone because they're in so much pain. There may be terminal agitation. We may be able to take them to our inpatient unit to address those symptoms because we can't control them in any other setting, okay? There's also a couple of other levels of care. So, for example, I've had a couple of patients who did not want to be at home at the end of life for different reasons. I had one who was only 42 years old, and he had a 5-year-old and an 8-year-old at home. He didn't want to die at home. But he had symptoms at the end of life. So there are hospice houses across the country. But hospice itself is not a place. It's a support, all right? So have you guys heard of About here in San Antonio? About is a hospice house. I think they only have 3 beds, maybe 5 for everyone. They will accept patients who are on hospice who have a life expectancy of 3 months or less. So, there are opportunities and options. But can we get the custodial care at end of life? That's not part of hospice. But if you do have symptoms, then we do have that inpatient unit, as he was referring to there on the corner in the medical center. Okay. But if you live in assisted living and you're like, I need more help, I don't want to pass away here, but maybe going into the nursing home side where you have someone who can provide that help you need, that you're no longer able to do for yourself, that might be an option too. So there are different options. Yes, healthcare. Yes, we have patients on the healthcare side who are on hospice. You had another question.
So I'm interested in your answer because my mother did die in a hospice facility in Chicago. And of course that was 12, 15 years ago, but I guess things have kind of evolved in that respect.
No, because there are across the country a few hospice houses, okay, like Abode. I used to work with a lady here in San Antonio who was like, I want to retire and open a hospice house, right? It's like, that's adorable. It's also very costly. But there are definitely hospice houses across the country, but they are sparse and scattered.
So within our family and friends, we're not constantly, but we see a lot of starting of dementia. And I noticed on your chart, it's about, 15% of dementia patients will become involved with hospice.
About 15% of hospice patients have a diagnosis of dementia.
I have a dementia, okay. And so at one point, what point do you say, the caretakers always need help. It's very obvious, but at what point can they raise their hand and say yes?
Okay. So one of the tough things about dementias is that they kind of all follow their own trajectory, right? You could have someone who's diagnosed with dementia and they're in the early stages and they could live for another 10, 15 years. So at what point do you say, it looks like this is 6 months or less? So people who have dementia, when you ask what did they die from, well, they may have died because they have an underlying diagnosis of dementia, however, something else happened. Typically, that's an infection. Aspiration pneumonia, urinary tract infection, pressure wounds that get infected, or they stop eating and they're unable to maintain their weight just because they're having difficulty swallowing. They're no longer hungry because once again the body was created kind of smart, right? Where the body says, I don't want this anymore, and they lose their appetite and stop eating. So you're really looking for at what point as your dementia progressed to the point where you're starting to see these infections, starting to see pressure wounds, starting to see weight loss. So you're really looking for that because like you said, that can be very early and you could still have years or even decades.
Thank you. I may be speaking for those who have regret that they didn't mobilize hospice for their parents. I think Mike has experienced that 25 years ago. There wasn't the awareness and appreciation of hospice. And maybe hospice wasn't promoting and educating like you are today so effectively. Can you do something today to further remove that regret?
The specialty of hospice and palliative medicine did not exist. So when you heard about hospice, you had to have an enlightened healthcare person who knew to bring it up, right? And yes, I am still of the era, I'm sure that you to a point are as well, where how many of you have seen doctors who feel that when they have to say there are no more treatment options that they failed, right? And so they push and they push and they push when what we're pushing for, we've lost sight of what's important. That is not the family's fault, okay? And I'm gonna give you a personal experience that I had a family. In 2025, as a hospice physician for 8 years, had a family member who was in the hospital. I did. Who was only 38 years old. Who had declined to the point where he was going to die. I had difficulty accepting it. As a hospice physician, I had difficulty accepting it. No one brought it up. No one brought it up. I requested a palliative care consult. And one of my colleagues came in and said, he's going to be dead in 24 hours. And he was. I did it this year. I hope that makes you understand that it is, number one, you are emotionally invested. And people who are not emotionally invested have difficulty talking about it. Okay?
if you've been seeing a doctor for years, is the doctor allowed to go to visit the hospice patients?
Yes. We have 3 full-time physicians in our San Antonio Vitas program. We have over 400 patients. We do go out to see patients based on kind of need and, you know, if there's things going on, et cetera. So if a patient is on our, and I think we're the only ones in San Antonio who send physicians out to see patients. We also have nurse practitioners who go out and see patients routinely. But yes, we can, and if you, for example, if you were on Vitas Hospice and wanted to see the doctor, you could request a visit. Having said that, we would triage, right, and say, these are the patients who, back when you were in the service, these are the patients who need to see someone right away, and when I have time, I really need to see this person who has requested a visit. Yes, sir. Small but mighty group.
I have recently had the experience with this group. They were outstanding in every aspect. Everything that she has talked about today was offered to me for my wife. The team that came to visit and take care of Joanne was led by a nurse called Amy Miller. She became part of my family. She was prompt, really helpful, and I've realized since Joanne passed away and thinking about Amy's visits, she would come, do her examination thing and talk to me or my daughters or sometimes Joanne. And she'd sit there and just talk to us, but always looking at Joanne. She was doing an evaluation. I would love to see those evaluation remarks that she recorded whenever she got back to the office. I don't think I can get them, but I'd love to see them. But you all did a wonderful job.
Thank you, sir. I know Amy personally. She is top notch.
She is a jewel.
Yes, she is.
Oh. By the way, I continually get emails or text messages from this group. Matter of fact, got one this morning because today was Joanne's birthday.
Do you talk to Jack? Have you met Jack? No? Jack?
I don't know.
Okay. It's a good team, though. Thank you. Thank you.
That team was outstanding.
So what is the difference between hospice and palliative care?
Hospice provides palliative care. It is part of what we do. You can get palliative care when you are pursuing treatment curative in nature. So if you're undergoing chemotherapy and this is like curative in nature, you can get palliative care to make sure that your symptoms are managed, making sure that you get the whole person care, right? In order to be on hospice, you have to have a prognosis of 6 months or less. Many patients are receiving palliative care services who do qualify for hospice, but for one reason or another, they may be afraid of the H word. They may be wanting to get one more chemotherapy, whatever that is. There are many patients who are eligible for hospice who are receiving palliative care services. The reimbursement is also different, but who cares about money?